Thank you so much. So some of you, a lot of you are here. A lot of other folks have asked us, of course, to have a recording because this doesn't work for everybody this time. So after this meeting, you're going to get one more email from us for your registration where we share the link. And the link is also somewhere in chat, but I've seen a lot of stuff going through, so it might be hard to look at there. So we'll send an email out with the actual link with a video recording of today's talk so you can see it again and share it with friends. And we'll do this for every one of our seminars. Everything is going to get recorded and posted so you can review at your leisure. Thank you. Next slide. All right, so what this is, it's an exciting new opportunity. The National Institute on Drug Abuse has become very interested in recovery-oriented systems of care. So there's a larger recognition that beyond formal treatment and beyond mutual help, there's all other kinds of creative new ways of providing recovery support over a longer term. And there hasn't been a lot of science on it. There isn't a lot of evidence. There isn't even a lot of knowledge on all the diversity of efforts that exist. And the goal of this program really is to do that more systematically, to share knowledge about what exists and how it works, and to connect people to then do more research on it to show how it works and that it's effective.
Oh, here. Yeah. That's great.
So that is the overall goal of that funded initiative from NIDA. For us in this group, we have decided to focus on recovery community centers. And I will say we had one definition in mind, but I think that's also a growing definition and diverse definition. And that's something we'll be working on as well in terms of highlighting the diversity and differences that exist between recovery community centers and how they operate and what they do and all those things, because it's an emerging and evolving system, of course. For our project that's going to happen over the next 5 years, we have two aims primarily. And one is to engage RCC stakeholders, so that's recovery community stakeholders, in research advancing activities. And when we talk about stakeholders, we really mean anyone who contributes to or can benefit from the support that recovery community centers can provide. And what we want to do is we want to engage in these activities, and I'll tell you what they are in a moment, and then we want to disseminate tools. So we'll record this meeting, of course. We'll also have papers on our website that might be useful, scales you might want to consider doing for questionnaires as you're talking with your participants who come through your RCCs. Any kinds of resources that we can collect, we will put on our website to share with everybody, and hopefully that help folks. So next slide. What we really hope to do here is bring together, as I mentioned, multiple stakeholders. I'm a scientist, John who's talking is a scientist. We tend to talk a lot to scientists and not nearly enough to folks who are not doing science. But what we really want to do is we want to bring together scientists, clinicians, folks who are running RCCs, folks who are considering going to RCCs, persons with lived experience. We want to have people involved. And our steering committee, who we talk with for all of our activities that we're doing, reflect some of that. And you can see the pictures here. And I've seen several of you already in our Zoom chat. Patty had said hello earlier. And I think everybody actually from our steering committee is here with us right now. So that's us, and we're leading it. Next slide. What we want to do, we'll get to a polling, is ask who you are. We're going to do a polling in just a minute. But here's the format for what we're doing today. Today, we're going to be doing the Recovery Seminar Series, which is a way for us to interact with you, to share some knowledge and gain knowledge. In addition to that, we'll be funding some pilot studies to help understand and document how RCCs can be effective. We will be supporting travel that people do to go to their conferences and their organizations to talk more about what RCCs are, what role they can play, to really just share knowledge about that. And then we are going to do some hands-on support that we're working on to really help people do research in their own RCCs and what that can look like, and develop that together. And then we'll have an advisory board meeting to stay on track with all of these things. Today, we're doing the seminar series. Our goal is to do, and this is probably less, it's 30 minutes of presentation where Dr. Kelly will share the biopsychosocial perspective on RCCs. And then we hope to talk amongst this whole group for the next 20 minutes. Next slide. So now our goal is to be multi-stakeholder and have multiple perspectives. And Hazel will do a quick poll for us to see who we actually have today. We have 323 people in our chat today. And if you could just indicate which of these categories describe, and check all that apply, because many of us have different hats and multiple roles. All right, Hazel, what is it looking like on your end?
I think many people are still voting, but maybe in
Good.
like 30 seconds or so, we could end the poll.
And here you can see that there's really a multitude of stakeholders that are involved and that need to be part of building a science around RCCs to make it inclusive and to make it accurate, what really reflect in the real world and communicating to other folks who are involved and the stakeholders in this. All right, how are we looking for poll results?
85% have voted, so is it okay if I end the poll?
Yep.
Okay, great. And now I will share the results.
Here we go. So you can see who we have today. So clearly we need to get more prescribers involved in here. That's one of the lower ones. But you can see that we are indeed a diverse group and we're hoping to build on that. And for future meetings, please do reach out to your friends and colleagues about this so that we can broaden our perspective here. But I'm so glad that so many of you are here and that we are able to share this time together. All right, now I just need to close this here. Yep, you can go to the next slide. That was totally fine. All right, so the resources we'll be putting on the website. I mentioned the video recordings of the seminars. For those folks who go to conferences and we can support them for conference travel, we will be putting the slides of those presentations there. For studies that we can fund with pilot funding, we will have outcome reports of those studies there. When we have meetings of our advisory board, we will have those summaries on our website. Scales for those who want to do assessments and questionnaires, we'll put those there with directions of how to score them in the actual papers. Conceptual things about the underpinnings. We'll talk about the biopsychosocial model today. There's other conceptual papers that are informative and might be helpful. They'll be shared here. And then lastly, the list of RCCs. If you're an RCC and you want to do research and you want to connect with scientists, please let us know who you are, and then we'll put together a list of RCCs that want to engage with us and other scientists to do research. All right. Next slide. And then this is, I just want to highlight, this is coming forward, and we will we'll send out information about this coming down the road about funding pilot studies in the conference application. If you have questions and you don't get anything, feel free to email me. And the last thing I want to mention here on the bottom here, you see recovery answers and the recovery bulletin. We are from, many of us, I should say, are from the Recovery Research Institute. John Kelly is the founder and director of RI, and he's going to be our speaker today. And one of the things we do, which might be interesting to you, is we bring out a monthly newsletter called the Recovery Bulletin, where we share a current science finding and we just describe the paper and then break it down in terms of implications for different stakeholders groups. So that's an easy and fun way to stay on top of some of the emerging science in recovery. All right, that's it from me. I'm going to turn it over to Dr. Kelly to talk about the biopsychosocial model.
Fantastic. Thanks, Bettina. Can you hear me okay?
We can.
All right, and now can you see my screen?
Not yet.
Okay. Do you need to stop sharing?
She did already.
She did? Okay, very good. I was trying to blame somebody else. Okay, here we go.
We can see it.
See that now?
Mm-hmm.
All right, you can see that. Elijah, hey, well, listen, I'm just delighted to be here with you all. Thank you for joining on this Friday early afternoon. Really appreciate it. Hopefully it'll be worth your while. I know many of you are very interested in this topic, and it's great to see. This is just really fantastic that NIDA has sponsored this project for 5 years, as well as 4 other projects around the country, all intended to increase the research on recovery support services. So isn't that, I mean, that's really good news, I think. And as I'll explain, hopefully today, a little bit to help us put us in the picture a little bit about why these recovery support services are indeed valuable for addressing these endemic problems related to alcohol and other drug use disorders, but particularly for opioid use disorders. So as Bettina mentioned, you know, this is the focus today on recovery community centers. They are sometimes referred to as recovery support centers, or sometimes they go by other names. Recovery cafes is another name for them in different parts of the country. So you may know them by different names, but essentially these are all of the same kind of general genre of recovery support services, and I'll explain more about what that is. So in terms of a rough outline, I'll start by really talking about what recovery community centers are, why and how did they emerge and grow, how might they work, and that's really the kind of the thrust of what I'm going to talk about today from a biopsychosocial perspective. And I'll touch on just a tiny bit today on what do we know about their impact, in part because we're going to dedicate a whole seminar, of which there'll be at least 10 coming up. Okay, so stay tuned for further seminars on this topic over the next 10 months or so. And we want to hear from you. So what do you want to hear about? What do you want us to talk about? And we'll try and cater to those needs and wants you all have, and some of which you expressed earlier, some of you who are here early and talked about it. But thank you for coming. So what are recovery community centers? Recovery community centers are intended to provide locatable sources of community-based recovery support beyond the acute care clinical setting. They help individuals achieve sustained recovery by building and successfully mobilizing personal, social, environmental, and cultural resources. And these collectively are sometimes referred to as recovery capital. And that's what I'll be talking a lot about today. What are they not? And now this is sometimes recovery community centers get confused with other services. They are not residential centers. They operate typically during waking hours. They're not sober living environments. They're not treatment centers. They're not 12-step clubhouses, and they're not clinical drop-in centers. Okay, so they serve a slightly different purpose, as I'll explain. Principles of recovery community centers. Again, they're a source of recovery capital at the community level. They provide different services.
I'm so sorry to interrupt. Does anybody have contact or know Amanda Dyer? Because in her screen, she's not responsive right now. Does anybody know her outside of here that knows where she might be or can get a hold of her? I'm so sorry to interrupt.
I'm glad you mentioned something because I was going to say the same thing.
Yeah, she works with us. I'm calling the Buffalo office now.
Okay, thank you.
Thank you.
Yes, I am.
Okay. Yeah. Hopefully she's all right. Okay. Thank you.
Carol,
And so
I'm on a Zoom call and Amanda Dwyer was on. Okay, she was passed out.
Oh, yeah.
Yeah.
Okay.
Yeah, Lori just ran in to get her.
Okay, I'm okay.
Okay.
Okay, yeah, thank you. I'm so sorry. It's all right.
That's all right. Better safe than sorry.
glad you're all right.
I'm okay. I'm doing pretty good. Yeah.
Okay. Yeah, so just coming back to the talk again. So principles of recovery community centers, they provide a source of recovery capital, as I mentioned, at the community level. They provide different services than formal treatment and offer more formal linkages as well as services and linkages to other kinds of agencies than do mutual help organizations, for example, which may do that informally. Another major kind of tenet of RCCs is that there are many pathways to recovery and all should be celebrated. What do RCCs offer? I guess as you look at this, you can say, well, what don't they offer? Because there's a ton of things that are offered by recovery community centers. It looks like this is what we found out in a recent study that we did several years ago now, but we're starting to publish the data from. You can see a variety of different kinds of services provided and linkages regarding mental health support, recreation, nutrition, healthcare, housing assistance, childcare assistance, Narcan training, medication-assisted treatment assistance, smoking cessation, as well as a variety of mutual help organization groups and peer-led groups. So a variety, as you can see, a vast array of services, again, trying to address the needs of individuals beyond the clinical setting. So why did these entities emerge and grow? Well, look, we've got this major problem. We hear about it every day right now in terms of the opioid crisis. But this opioid epidemic, of course, occurs amidst a more endemic problem that we have in nearly every middle and high income country around the world, including, of course, the United States. in terms of mortality, disease, disability, crime, and economic burden. This is the top public health problem. What do we do about it? We've been trying to address these problems for decades, if not centuries. Certainly in the last 50 years, I've just been reflecting on the past 50 years in relation to the really concerted federal focus under the auspices of the so-called war on drugs. But really what that did was really make a pointed effort to address these endemic problems from a large-scale federal and state perspective. And we've made a lot of progress. If you think about all the things that we have learned in the last 50 years about the causes of addiction, that it's multifactorial, but it has a strong genetic component. About neuroplasticity, that the brain changes in response to exposures to drugs and in recovery. We've learned about the epidemiology and risk factors among certain populations, the multiple pathways to recovery, the clinical course of treatment and recovery, and the different types of treatment that have been discovered and operationalized and tested in the last 50 years, including, very importantly, medications for opioid use disorder, which, of course, a large part of the grant is focused on. And I think the addiction field now is really evidencing another paradigm shift. Here's the paradigm shift now. It's really looking at the recognition of addressing not just clinical pathology, not just acute care stabilization, detoxification, stabilization, but recognizing the needs of individuals beyond pathology. We call these things social determinants of health sometimes, or recovery capital. So why has there been this shift in focus and this new paradigm emerging? In part, it's because what we've learned about the longevity or the clinical career of addiction, it tends to be long, too long. The question is, what can we do to shorten it? How can we get more people into recovery sooner? How can we get them to stable remission sooner? When we look at this timeline, for example, you can see that on the left-hand side, it takes 4 to 5 years after the onset of a substance use disorder before people start seeking help. Now, part of that is just the stigma, the fear of discrimination, the shame that people feel that prevents them from seeking help. When the pressure gets too great, they start to seek help. Again, these are in adults with more severe conditions, the kind of people that we see in formal specialty treatment who have moderate to severe substance use disorders. And look, it takes about 8 years in adult samples to get 1 year of remission, okay? So that's a long time to get that first year of remission and about 4 to 5 treatment episodes. And on the right-hand side, you can see even after achieving that first year of sustained remission, which in and of itself is a huge achievement, it takes 4 to 5 years of continuous remission before the risk of meeting criteria for a substance use disorder in the next year falls below 15%. Why 15%? Because 15% is the annual risk in the general population. So to be no more likely than anybody else in the general population of meeting criteria for substance use disorder in the following year, if you've already had it, takes 4 to 5 years of continuous remission. So look at that, and you think, well, this is a long time. We're talking, what, 17 years to reach stable remission. Is there anything we can do? Is this an inexorable course for substance use disorder? Or are there things that we can do to shorten the time to remission and shorten the time to stable remission? And I think the answer is yes. Now, historically, we have focused very necessarily on acute care stabilization because people's lives are at risk, particularly in those early hours of detoxification. They need medical attention to prevent death, sometimes particularly with alcohol, of course, and stabilization. And those acute care services are critical. The next question, of course, is what do we do next? We've become very adept at putting the fire out. I make this analogy of this burning building that we've done a good job of recognizing the building is on fire and we've been able to put the fire out. But the next question is, we've tended to walk away from the building then without really addressing the needs to refit the building and rebuild the building. And what I'm talking about is the next phases, which is architectural planning, providing building materials to refit the building. And I think very importantly, providing a building permit so that the building can start to be rebuilt. We know, of course, that many people who have drug histories have drug convictions, and those convictions can overshadow attempts to recover by virtue of the fact that denying them vital assistance in terms of housing, education, childcare, even opening a bank account because of prior convictions. So those building permits are critically important, and that, of course, implies legal and legislation issues as well beyond the kinds of recovery capital issues that we normally think about. So historically, we've had these two ways of addressing these endemic problems, right? We've had our clinical services, which have done a fantastic job in terms of detox stabilization, providing acute care treatment, and mutual help organizations like AA, 12-step groups, as well as newer ones like SMART, LifeRing, Women for Sobriety, that have done a good job in addressing the needs over time. But there's been this third now additional wave of what we call recovery support services, which really have emerged and grown in the last 20 years, and a major part of which is in recovery community centers. So here's an interesting graphic. This is from the National Institute of Drug Abuse. Take a look at this, because this is what NIDA says, the National Institute of Drug Abuse says, are components of comprehensive drug addiction treatment. And it says at the bottom, the best treatment programs provide a combination of therapies and other services to meet the needs of the individual patient. Now look around the edge of this circle. Now in the center, we can see the kind of things that we normally associate with treatment: assessment, screening, brief interventions, etc. And look around the outside, though, they are the kinds of things that we would think about in terms of recovery capital. Medical, educational services, legal services, family services, vocational services. So we wouldn't have historically viewed these as being part of a clinical treatment program, but now the world is changing because we're recognizing this paradigm shift of the need to attend not just to clinical pathology, but to the things that can provide chronic sources of stress for people when they don't have these other resources that can help them recover. And of course, recovery community centers, which I'm going to focus on today, and this grant is focused on, is one of a cadre of recovery support services, including mutual help organizations, as I mentioned, recovery coaching, recovery residences, and recovery supports in educational settings, as well as long-term clinical models of care. So how might recovery community centers work? How might they confer benefit and help reduce relapse risk or recurrence risk for substance use disorder and enhance remission and quality of life? Well, there's a number of different levels of mechanisms, of course, when we think about behavior change and way people change. There's social mechanisms, psychological mechanisms. And when we think about social support services like recovery community centers, these are the kinds of things that come readily to mind. Other things, though, are happening underneath, inside the body of people, right? Biological, cellular changes. There's even atomic, subatomic, quantum level changes. There's vibrating strings of energy, of course. And then right at the very bottom of it all is Engelbert Humperdinck, who I'm not going to talk about today, but I think he's responsible. Well, some people tell me, may be responsible for everything that happens. I don't know. But the point here is that there are multiple levels, and I'm going to focus today on a kind of a biopsychosocial model. Now, we know, of course, today very well, given what's happened in the last 50 years of neuroscience, of genetics, we know very clearly, we can see through the brain imaging that's been developed, that the neurocircuits of reward, memory, motivation, impulse control, and judgment are all affected to varying degrees based on degree of exposure over time. Not only functionally, structurally. You don't have to look very long or very hard to see how the brains of individuals who are chronically exposed to neurotoxic substances can change functionally and here structurally. Now, when we think about relapse risk in those early months and even early years of recovery, the body and the brain is going through vast changes in the absence of drugs and alcohol. And there are two major factors which are associated with relapse risk because they're damaged and they're downregulated or changed as a function of exposure. One of them is increased sensitivity to stress, and the other one is decreased capacity to experience normal levels of reward. Okay, so these two factors, which we know exist, can predispose people to a return to substance use. If you imagine you're stressed out and you don't even experience the normal rewards that normal people feel because your brain is down-regulated as a function of exposure to abnormally high levels of reinforcement in the way of psychoactive drugs. Now, when you look at common precursors to relapse, of course, you can see that the goal of treatment and recovery support services shown at the bottom is designed to help reduce exposure to certain cues in the environment or help people cope with those cues. Some cues you can't avoid, time of day, day of the week. And also to help offset that stress, the stress involved, that hypersensitivity to stress that we know occurs early in recovery, as well as substance-induced relapse. And so the way that they work is try and offset that risk by shifting the social environment, changing our psychology and emotion, and also shifting our biology. We can do that from the outside in, as well as the inside out in the form of medications, of course. So recovery community centers, their goal is, of course, to help people achieve and sustain remission and enhance their quality of life. How do they do that? In theory, they're supposed to work by helping individuals build recovery capital in a rich social environment that's supportive, and thereby induce these biological, psychological, and social changes that will enhance the chances of ongoing remission and improving their quality of life. So a question I asked myself a while ago is, in terms of the neuroscience of recovery capital, if addiction is a disease that affects the brain's neurocircuitry, could jobs, housing, peers in recovery actually help change the brain, help buffer that stress, upregulate those downregulated receptor system, and increase the chances of long-term remission? So not just socially and psychologically, but what about biologically? So let's first look at stress. Recovery community centers are rich social enterprises, right? Filled with people with that lived experience. What does that do? It helps to mitigate feelings of isolation, of shame, of uniqueness, terminal uniqueness, of guilt, and increases that sense of universality, sense of belonging, and helps to instill hope that can mitigate stress. In the words of Tracy Chapman, some of you may know this song, a few years ago now, I'm probably dating myself, but one of my favorite songs, Fast Car, and one of the lyrics in the chorus there, it says, "And your arm felt nice wrapped around my shoulder, and I felt like I belonged, and I felt like I could be someone." Now think about that. She's not talking about recovery community centers, of course, but I think those lyrics there epitomize what happens in part at recovery community centers and in recovery support services in general, is that people feel like they belong. That's a very important human need. And also that they can find their feet and be the person they are meant to be. So this is just to show you just the social aspects, the mutual help, the peer meetings, the recovery meetings, etc. It's a very rich social enterprise. And given that, what happens with those social mechanisms, we're understanding more clearly now how social factors in this area of social neuroscience, how social factors can actually mitigate that stress pathway that can induce relapse risk or elevate relapse risk via enhancing a number of different neurochemicals and neuroendocrine factors which produce a chemical cascade which can mitigate those stresses. So we're learning more about that in terms of how our social connections can offset stress. Other work with animals have shown that animals, rats in this case, actually will choose, regardless of how addicted in these models, how addicted rats are, they will choose social interaction over drugs, okay, when given the choice. Interesting, right? Now, they're more likely to choose drugs, however, when the social reward is delayed or they're punished for choosing a social reward. Now, what are the human implications of that? The inaccessibility to peers or the experience of social exclusion, discrimination, or ostracization may similarly increase the risk of relapse in humans. So that notion of being welcomed, of belonging, of being accepted can be key as a competitor that can compete for drug use. And this is why this is one of the mechanisms through which recovery community centers work. When we think about not just stress, which is the top one here, but what about the down-regulated capacity to experience normal levels of reward? What can recovery community centers and the social factors involved do, as well as the recovery capital access do, to offset that risk? Well, look at these graphs here. These show this line going up to the right-hand side, which indicates a strong linear association, in this case, between social status and the capacity to experience reward, and social support also correlated strongly with the experience of reward, mediated by dopamine D2 receptors. And these particular receptors are receptors in our brain that allow us to experience reward. The more of those receptors that you have, the greater your ability to experience reward. And you can see social status, access to resources, in other words, is correlated with higher amounts of these D2 receptors, experience more reward, and also social support, how much support you have. Now, those are correlations. What about if we were to manipulate the environment? What happens when you experimentally manipulate the environment and you take primates who are isolated and then put them into troops where they're with other peers? And what happens to these dopamine D2 receptors? Do they go up, as we saw in that human study? Increase? Yes, they do. They do actually increase. In fact, when you take monkeys who are isolated, and when they're isolated, they show no difference in their dopamine D2 receptors. You put them into groups where they love to be because they're primates like us, their dopamine D2 receptors go up, especially for those who are dominant, the monkeys that were dominant. What's the definition of dominance? Easy access to resources. Now, all these monkeys were exposed to cocaine, and the monkeys that showed the elevation in the dopamine D2 receptors showed a reduction in cocaine use, okay? So what are the implications here when you think about this in terms of for human beings? Facilitating greater access to and availability of recovery capital, access to resources in a rich social environment may instill hope, empower people, help them have more control over their environment, increase social contact and social mobility through the environment, and thereby induce neurochemical changes that can reduce relapse risk. So not just for stress, but also for the capacity to experience reward. The final thing I'm going to say, just touch on very briefly, is what do we know about the impact? And I'm just going to mention a couple of things here in terms of what we're finding from a prior study that we did, the first rigorous systematic study of recovery community centers, which we did a few years ago now in New England and New York State. And we have a few papers. These will be on the website for you to access down the road. We've got a preliminary page up on recoveryanswers.org, our website right now, where these will be housed, but you'll be able, you can ask for these. But some of the findings are interesting in terms of who's using these centers. So this was about 35 centers. Right now, I can tell you that these things are expanding all over the place. Right in Massachusetts, where we live, is where I live and where the Recovery Research Institute is. There are now 26 centers just in Massachusetts, okay? There were 35 in all of New England and New York State a few years ago. So that tells you how much these things are growing. And they're all funded by the state here in Massachusetts, 26 of them. But look over on the left-hand side. Here's an interesting fact. Yes, it caters to people who are in the early phases of recovery, that first 6 months, that first year. That accounts for, about half. But look at about 40, yeah, about half. But look at the other half. Also, many people in that first 5-year period, in other words, that first few years, which has the elevated risk for reinstatement of a substance use disorder, are utilizing these centers. Look on the right-hand side, primary substance. Opioid use disorder individuals are disproportionately overrepresented in these centers. Alcohol, of course, you would expect alcohol to be because it is by far and away the largest drug to which people become addicted. 75% of addiction cases are alcohol. So opioids are overrepresented. Now, why is that? When we look in our national recovery study, we can see these nice changes, these positive changes in these indices of quality of life and functioning and growths in recovery capital. But take a look at the opioid group. This is in the first 5 years. Look on the right-hand side here regarding recovery capital. They are 1 standard deviation lower than people with cannabis and alcohol problems on average. Okay, they start off their recovery journey a full 1 standard deviation lower in terms of recovery capital. It takes them 2 to 3 years to get to the same level, just as the people with alcohol and cannabis use disorders. Okay, now that's not high, but even after 2 or 3 years, but it's at the same level as people with other drug use disorders. So they're disadvantaged. They're more stigmatized, more marginalized. They have less recovery capital and also much lower quality of life. Look on the left-hand side. So individuals with opioid use disorder, overrepresented here. So there's something about opioid use disorder in particular that these particular centers may hold particular value for in terms of helping those individuals increase recovery capital and also increase their quality of life. Now, when we look at conceptually, remember I showed you at the beginning, you know, what's the mechanism by which recovery community centers or recovery support centers are supposed to work? Well, they're supposed to provide increases in recovery capital, which is then, it will then in turn increase things like quality of life and functioning, hopefully decrease psychological distress, and help therefore to increase the chances of ongoing remission. And what we found actually, when